Hi, everybody. It's Dr. Patricia Coughlin, and I wanted to let you know about a 2-day webinar that I'm going to be offering in conjunction with ISTDP Israel on December 6th and 13th. The focus of this webinar will be on issues around emotional closeness and defenses and barriers against that in the therapeutic relationship. So we're going to be looking at how to understand these defenses, identify them, and work with your patients so that they, and if they will, be willing to remove them. Because when patients are guarded and detached and not emotionally involved, doesn't matter how effective your treatment is. They're not present, they're not engaged, and you're not going to be effective. This whole topic is something that Davin Liu really focused on and made some real innovations in. So when he started experimenting with more active ways to intervene, particularly in order to identify and then remove defenses, which left in place would become a resistance, he, of course, was dealing with the formal defenses that we're all very familiar with. Intellectualization, somatization, projection. But as he was working with patients, he not only experimented himself and videotaped the sessions so he could review them, but when the treatment was completed, he would also ask patients to come back for follow-up and look at some pivotal sessions to get their feedback. And it was actually in one of those sessions that one of his patients highlighted what Davin Liu came to call tactical defenses. These are defenses used interpersonally as opposed to intrapsychically, right? Like the formal defenses. These are defenses that are designed to keep other people, including you, at a distance and out of the patient's intimate life. And so it was when this patient was saying to me, you kept trying to nail me down and press me to open up, and I kept trying to find a different tact, like diversifying, changing the subject, things like this. So Davin Liu, a light bulb went off, and he realized that patients were using these kinds of tactical defenses, both verbal, like being vague, contradictory, diversifying, or nonverbal, right? Like avoiding eye contact, having their legs and arms crossed, right? These signals that the patient is really not available. And these defenses, which again are called tactical defenses, must always be prioritized over defenses against particular feelings, for example. So one of my colleagues, Josette Tenhave de la Gib, I hope I'm pronouncing that correctly, really has a wonderful analogy for this. If you think of the person you're dealing with as a house, they have a front door, and then they usually have a back door that leads down to the basement, right? So very often, therapists are so excited, especially depth-oriented, dynamic therapists, about getting to the bottom of things, getting into the cellar, where all of those sexual and aggressive impulses are hanging out, that they try to go there, they try to sneak in the back door when the patient has the front door closed. And so she's saying you always have to deal with the front door first. If the person hasn't invited you in, you have no business poking around, right? And also, you're actually not going to get a therapeutic result. And so we want to, again, understand these defenses, identify them, and work to remove them. Otherwise, the therapy is destined to fail. So as I said, we're going to be going into great depth about this in the seminar. I'm going to show you all kinds of different presentations, ways that patients detach or erect barriers against closeness, against opening up and connecting in any kind of authentic way. And again, as long as that's the case, no matter how effective your treatment may be, theoretically, the patient is not available for it. And I can't tell you how many times I've watched videotapes where the therapist is trying very hard to get connection and elicit feelings when the patient is literally unavailable, right? They're still wearing their coat, their arms and legs are crossed, their eyes are downcast, and yet the therapist is talking away, right? As if they have a patient in the room. So we want to be able to identify these defenses, right, that knit together to form a wall against any genuine contact. So we have a greater likelihood of being able to get through those, help the patient see it, see how they're keeping themselves alone, how they're undermining treatment efforts, and how if they continue, which is their prerogative, right, to hide and behind this wall, that in fact failure will be the result. And these really are typically patients who have a very heavy self-punitive mechanism in their lives. They have sterile relationships. They don't tend to do well at work and things like this. So we can see the self-destructive pattern in the relationship with us, keeping us at arm's length. And this can also come in more subtle ways. I'll never forget, it was probably the first year I was doing ISTDP, where I came to realize that this man, while he looked at me and talked a lot, he went on in such minute detail and would sort of drone on in a monotone where I just was like losing interest. And he had mentioned that a couple of previous therapists had actually fallen asleep on him. And so I realized that he, instead of actively blocking himself, he was subtly discouraging other people from becoming interested in him. So there are all kinds of ways that this can show up. But really being able to work effectively with these defenses against emotional closeness will greatly enhance your effectiveness, especially with character disordered patients, who have this kind of character armor of passivity or defiance and acting out or whatever it might be. So I hope you will join us in December. I'm going to leave a link right below here so that you can sign up and register. And I look forward to seeing you there. Bye-bye.